really quickly sort of the legal and regulatory considerations. And I find this really interesting. I know this wasn't sort of the topic, so I included this anyway, but I'll go through it relatively quickly. Because the question is when is an AI, first off, what is software in general that's not doing a specific device function, a medical device, right? And the idea is that it's when it performs a medical purpose. I had promised my team I wouldn't talk about Europe. In Europe, if I do anything except for like an Excel spreadsheet of device readings, medical device. In the US, it's a little more nuanced, right? So it has to perform a medical purpose, right? It's not just informing the provider, it's doing some clinical decision making with the provider. When that happens, super intensive regulatory approval process, right? So the question then is, now that AI exists, where does it cross that line? And it's much harder to figure that out than it is with, the sort of lines that were already hard to draw with software as a medical device. And that's something that's actively being figured out at FDA and other regulatory bodies. That is then sort of compared against assistive AI, which now it's almost three levels. You have operational AI, which is helping with operation efficiency. Then you have assistive AI, which in Europe, again, no difference between assistive and medical device. But in the US, it's like, okay, we're just helping the provider look at things and know what to look at. And we're basically we're like a graph. We're helping the provider look at a thing and detect the trends and make decisions, but we're not making the decisions for them. That's assistive. And then software as a medical device is, we're also saying, like, look at this patient. That's the indicator or predictive indicator of heart failure, things like that. So that said, this is amorphous. Even under the standards of like healthcare law, which is amorphous in general, and maybe not amorphous, but it has lots of areas that are sort of gray line. This is particularly that way. There's also huge sort of professional and administrative debate as to where this should be. Because the truth is we don't got enough providers, we don't have enough care staff to handle the silver tsunami, which is I roll my eyes at the term, but the silver tsunami that's coming, right? And that's pretty much here. So it's not the question of, how much care can be given. It's not the question of, do you want the doctor to call the patient every day or the nurse to call the patient every day or have AI do it? Really is the question at scale of, does the AI do it or does no one do it, right? Because we just don't have the staff to do these things manually. So where that line is drawn is a very interesting debate that I won't go too much further into this. But yeah, we have a few blog posts on it. It definitely, I'd love to hear thoughts on it, things like that from the folks on this call. But definitely an interesting aspect of this. And even that debate, before those lines are drawn, as you can see from the operational efficiency versus what most has been built out, right, for AI so far in RPM, like hugely meaningful for where the money and resources go. And it takes a while for these things to be built. So even without those lines drawn clearly yet, the debate and the back and forth and who's in power, administration, things like that, super indicative of where this is going and where money's put. I mean, we have to make that decision, is the truth, right? Sort of reading the tea leaves and being like, okay, this is the most useful AI, this is the safest AI, but also this is the one that we can do given the current criteria that exist for clinical decision support versus medical device, things like that. All that said, standard of care hasn't changed. So as much as I am a cautious proponent of AI and RPM, maybe I'm just a proponent, but at the same time, use some caution. The legal standard for anything except for the very finely defined medical devices is that regardless of the accuracy of the AI, which we take very seriously, others do in the industry also, but regardless of it, the legal standard is you're kind of on the hook as a decision maker. The AI is to help you see the data, summarize the data, but because of the way that these things are being built, not as medical devices that are validated for individual decisions, and even how would you do that for AI? Because they'll make 50 decisions in the same 10 minutes. It's not like a ECG and it looks at the ECG and the AI goes, AFib. it's LLMs are doing just tons of different data, and we're building them so they're as little black box as possible. Even then, there's a little bit of black box to it, right? So all that said, you still have to make sure that it's accurate and that you're doing things correctly, and that you don't get complacent with the AI. That's one worry that you hear about a lot, which is, well, the AI always bubbles up the summary, and the summary always talks about if the patient has a fall risk. We had a lot of trouble. We were testing our AI. We tested it hundreds of times, and it was never wrong. But just by the manual testing, right, of our current like risk bubbling AI, it was. I almost don't want to say it was never wrong, because the truth is that by definition, even if we tested it 100 times and it wasn't wrong, they will be wrong sometimes. It is not a one-to-one process. So you can't, the complacency to miss that is hard to you have to put things in place to make it so that it's hard to I don't know, that you prevent it as much as you can, right? And the way to do that is to avoid those black box neural networks where it doesn't cite their sources, right? If the AI flags a patient, has to provide the underlying data, and the provider really needs to be pushed, not pushed, but, when I say provider, I really mean clinical staff, right? Whoever the scope is for that patient should be looking at that data to confirm, and also be looking at the data more generally and not relying too much on